Spine-related pain. 1. Know common causes of neck and back pain to differentiate acute and chronic, inflammatory and mechanical disorders. 3. Recognize the red flag signs. 4. Describe clinical and radiological investigations. 5. Understand the basics of conservative and surgical treatment. All notes move to ONT Clinical Skills Workshop 2. Spine and bone. SC57A painful shoulder problem. 1. Clinical approach to patients presenting with shoulder pain. 1. History taking. 2. Physical examination of shoulder to confirm the diagnosis. 3. Clinical reasoning. 2. We apply this in 3 common shoulder problems. Be able to differentiate. 1. Frozen shoulder. 2. Impingement syndrome. 3. Rotator cuff tear disease category. Congenital trauma. Inflammatory degenerative. 2 more others. Painful shoulder history. Pain. 2 important questions. 1. Is it really shoulder pain? Black small square. Can you lie on the affected shoulder during sleeping? If yes, unlikely to be shoulder problem. Black small square. Show me where is your shoulder pain. Shoulder, anterior, diffuse, posterior, etc. Neck, cervical spine problem, interscapular region, thoracic spine problem, chest, head or chin. Black small square. Even if the patient point to his/her shoulder, shoulder pain, radiculopathy pain. C5 cervical radioculopathy, referred pain, e.g. diaphragmatic irritation from cholecystitis. 2. What is the nature of pain? Is it rest pain or mechanical pain? And, black small square. If mixed, then which is the more predominant pain? Rest pain comes at night time, may improve with movement. Mechanical pain associated with movement. Neoplasm, systemic inflammatory joint disease, musculoskeletal infection, frozen shoulder, calcific tendonitis, fracture, shoulder dislocation, superior labral lesion anterior to posterior slab, impingement syndrome, rotator cuff tear, osteoarthritis of shoulder, synovial and dermatosis. 3. If the pain is mechanical, is there any preceding injury? Black small square. History of trauma including mechanism of injury. No injury, trivial injury, definite significant injury. Helps to predict diagnosis, exacerbation of symptoms of a pre-existing pathology. No new recent damage. The injured tissue is weakened by pre-existing pathology. Tissue is damaged even under physiological loading. Degenerative overuse problem. The injured tissue is initially normal tissue damage because force. Ultimate failure, strength of tissue. Traumatic problem, e.g. osteoarthritis of shoulder, e.g. degenerative rotator cuff tear, e.g. fractured distal clavicle. Shoulder dislocation helps to predict treatment. Low probability of healing. Those symptoms may improve with non-operative treatment. If fail, then consider surgery. Potential to heal. 4. What is the age of patient? Young patients, elderly patients. Not so young. 60-70 yo. Trivial or no injury, overuse problem. Shoulder abuser. Impingement syndrome, low energy trauma in weakened tissue, degenerative problem. Definite injury, higher energy trauma in normal tissue, e.g. fracture clavicle, likely lesion, Bankart lesion plus lab, tear in superior labrum from anterior to posterior, recurrent anterior shoulder dislocation, rotator cuff tear, in degenerated tendon, biceps tendon rupture, less recurrent shoulder dislocation, SS plus pain, shoulder weakness, cannot elevate, 90O, pseudo, paralysis, Puapai sign. 5. Duration and progress of pain. 6. Severity of pain. 7. Aggravating factor, relieving factor. 8. Response to treatment including analgesics, PT, etc. 9. Stiffness, decrease in passive ROM compared to the past. Weakness, due to motor unit problem. Need paid to distinguish. Instability, deformity, swelling, hotness or even discharge, crepitation, clunking, snapping, dominant shoulder, systemic, constitutional symptoms, risk factors, occupation, sport, past health, social history, etc. Activity of daily living. Combing overhead activity, forward flexion and abduction, dressing, external rotation, buttoning of bra, lady, scratching the back, both man and lady, internal rotation, extent and severity of the problem. O. Involvement of one plane or global involvement of the whole shoulder, e.g. frozen shoulder, osteoarthritis. O. American shoulder and elbow surgeon score, as a score, no need to remember. Physical examination of shoulder, general principles. O. Exposure, black small square. Man, take off all clothing above waist level, black small square. Lady, expose both shoulders above breast. O. Position, standing or sitting. O. Examine normal side before abnormal side. O. Convenient to examine both shoulders at the same time. Inspection, a lot of observation at the back. O. Deformity, including swelling or mass, uncommon. O. Muscle wasting, common in rotator cuff. Compare both sides. O. Wound or scar. O. Sign of inflammation, infection, sinus tract. Palpation. O. Initial position of shoulder, black small square. Hand behind back, black small square. Extend and internally rotate the shoulder. O. Examiner palpate the followings: black small square. Sternoclavicular joint, black small square. Clavicle, black small square. Acromioclavicular joint, black small square. Acromion, anterior, posterior, black small square. Greater tuberosity, black small square. Bicipital groove, long head of bicep, black small square. Lesser tuberosity, insertion of subscapularis. O. Localized tenderness. O. Effusion, range of motion. ROM, active before passive ROM. O3 planes, sagittal plane, coronal plane, axial plane. O6 directions, position. Initial position of shoulder procedure normal if forward flexion active sagittal plane, standing sitting 0 deg flexion 0, deg abduction. Ask patient to actively forward flex the shoulder. Measure the amount of flexion in the sagittal plane along an imaginary vertical line along the trunk. Normal max range, 150-180. Hyperflex also normal, symmetrical symptom free e.g. no pain. If abnormal, then proceed to passive RUM. Forward flexion passive sagittal plane. Examiner forward flexes the shoulder of the patient. Watch the patient's face. No need to immobilize scapula. Measure the amount of flexion in the sagittal plane along an imaginary vertical line along the trunk. Same as above. Extension abduction active. Coronal plane. Ask patient to actively abduct the shoulder till maximum. Mainly involves glenohumeral joint. Measure the amount of abduction in the coronal plane along an imaginary vertical line along the side of the trunk. Normal max range, 150-180. Symmetrical, usually smaller range is the problematic site. Symptom-free normal scapulothoracic rhythm. Normal reverse GHJ moves first, 120. Then movement at scapulothoracic junction, 60. Overlapping in the middle movement begins at scapulothoracic junction. Rotate scapula first, shrug up shoulder. Reverse implies pathology in GHJ. Pain, stiffness, weakness. Cannot move GHJ despite asked to actively abduct the shoulder. If abnormal, then proceed to passive RUM. Position. Initial position of shoulder procedure normal if abduction passive, coronal plane, standing sitting 0 deg flexion 0, deg abduction. Examiner abducts the shoulder of the patient. Watch the patient's face. No need to immobilize scapula. Measure the amount of abduction in the coronal plane along an imaginary vertical line along the trunk. Normal max range, 150-180. Symmetrical symptom FRE abduction. External rotation active axial plane, 0 deg flexion 0 deg abduction. Medial aspect of elbow touching the side of trunk. Ask patient to ER with elbow touching trunk. Normal max range, 45-60. Symmetrical. If abnormal, then proceed to passive RUM. External rotation passive axial plane. Examiner ER the shoulder with elbow touching the side of trunk. Same as above. Internal rotation active axial plane. Hand behind back along the midline and lumbar level. Thumb. UP position. Ask patient to move a thumb along the midline of spine as much as possible. Measure the amount of internal rotation as highest level of vertebrae that the tip of thumb can reach. Symmetrical symptoms FRE. If abnormal, may proceed to passive RUM. Internal rotation passive axial plane. Examiner passively moves the hand up along the midline of spine as much as possible. Measure the amount of internal rotation as highest level of vertebrae that the tip of thumb can reach. Very uncomfortable. Avoid doing it as when limited by pain. Same as above. Circumduction equals combined action. O discrepancy between active and passive RUM suggests problem in neuromotor unit responsible for the corresponding motion, not due to stiffness in joint. Black small square, tendon problem. Black small square, muscle problem. Commonest reason in elderly, full thickness full width rotator cuff tear, supraspinatus. Black small square, nerve problem. Peripheral nerve root central nervous system. Muscle power, O rotator cuff. Supraspinatus infraspinatus subscapularis origin supraspinous fossa of scapula infraspinous fossa of scapula subscapular fossa of scapula insertion upper 1/3 of greater tuberosity middle 1/3 of greater tuberosity lesser tuberosity of humerus innervation suprascapular nerve upper and lower subscapular nerve action initiates abduction of shoulder joint active in range 90 abduction external rotation of shoulder joint internal rotation of shoulder joint position standing sitting initial position of shoulder 20 forward flexion 60 abduction empty can position thumb pointing downward that is internal rotation 0 forward flexion 0 abduction maximum external rotation hand behind back along the midline and lumbar level hand rest on the back procedure. Ask patient to perform resisted abduction of shoulder, apply downward thrust. Ask patient to perform resisted ER of shoulder. Examiner try to IR Gerber lift off test. Ask patient to lift the hand off the back. If succeed lift off test is negative, that is enjoy functional power of subscapularis, MRC grade 3 or above. Non-functional signs of power. 3 perform aptly drop arm sign. Position. Standing passive maximum abduction patient is asked to lower her arm can control above 90 but arm drops suddenly when abducted to 90 dec EG in full. Thickness full width rotator cuff tear. Near drop arm sign. Position. Standing passive maximum ER patient is asked to maintain the ER arm swings back towards midline EG in full thickness full width rotator cuff tear. Lag sign. Position. Standing. G hand on back and is passively lifted off from back by examiner. Patient is asked to maintain the lift off position. Patient fails to maintain and hand drop EG in full thickness full width rotator cuff tear. O deltoid, biceps. Special tests. O impingement syndrome. O irritation of long head of biceps. O acromioclavicular joint arthritis. O instability. Shoulder problem, pain, rest pain, neoplasm, painless swelling present with pain only when it is in a late stage, rapidly growing tumor pending pathological fracture pressure effect on adjacent structure painful in uncommon neoplastic condition e.g. osteoid osteoma, relatively uncommon systemic inflammatory joint disease for example rheumatoid arthritis other joint involvement deformity, swelling, morning stiffness, etc. Musculoskeletal infection acute bacterial infection. fever, chill, rigor. Superficial versus deep chronic infection, low-grade fever swelling, sinus discharge, etc. Rest pain frozen shoulder, adhesive capsulitis primary versus secondary frozen shoulder, idiopathic frozen shoulder, etiology not well understood typically found in patient in 5th-6th decade of life risk factors, diabetic mellitus, female secondary, other painful pathology and shoulder adjacent area pathology, initially inflammatory changes of the entire rotator cuff and underlying capsule with time. Capsules stick to the humeral head and the infraarticular synovial gusset may be obliterated by adhesion. Symptom: progressive pain and stiffness of the shoulder stage phase SSMX freezing